Thank you for the introduction, and thank you, Foundation, for inviting me to speak today. So I'm going to be with you for a while because I'm doing two talks. The first one is on aplastic anemia and the second one on PNH, and I hope I will show you how these two are connected. So let's see, here we go. So these are my disclosures. The only pertinent one is my connection to Novartis. I consulted Novartis, and they're making L-Trombopac, one of the medications which is used for aplastic anemia I'm going to talk about today. So first of all, the term aplastic anemia. So basically, aplastic anemia is a bone marrow failure, and bone marrow is the place where all red blood cells, platelets, white cells, all of the blood cells are made. And bone marrow failure means that this organ doesn't perform its function by not making enough of those cells. And, typical manifestation is what we call pancytopenia, which is lack of blood cells. Pancytopenia meaning all of the blood cell lines are deficient, meaning patient has anemia when you have low red blood cell count, low white cell count or leukopenia, and low platelet count or thrombocytopenia. So I'll be using these terms interchangeably. The aplastic anemia as a label for this condition was coined by Paul Ehrlich. He was a German scientist who described this condition in the 19th century. And this was described as non-malignant hematological disorder. That means it is not cancer, characterized by injured and markedly hypocellular marrow, which is not effective and means it doesn't produce cells. Hypocellular, low cell count. So you're expecting to have certain cellularity in the bone marrow, which is usually decreasing with age. We commonly calculate it using a very simple formula. So if you're 50 years old, your cellularity should be 100 minus 50 or 50%. So if it is less than that, that means the marrow is hypocellular. So at the time when Ehrlich described this condition, anemia was part which was easy to assess, and that's why it came out as aplastic anemia or not aplastic pancytopenia. So there are two subtypes of aplastic anemia, and one of them is constitutional or inherited bone marrow failure, whereas genetic predisposition and additional congenital abnormalities sometimes may affect other organs. Not in all patients. About half of the patients will just have marrow failure, and not in other organs will not be involved. We mostly are going to focus on acquired aplastic anemia, which is the most common subtype of aplastic anemia and is related to, most of the cases are related to autoimmune suppression of bone marrow function. So a couple of slides on constitutional marrow failure or constitutional aplastic anemia. If we take all of the aplastic anemia patients, about 10% of them will have this subtype of aplastic anemia. And there are different genetic disorders, different genetic abnormalities, which lead to not only marrow failure, but in some patients, other abnormalities. The most common ones are Fanconi anemia, telomerase biology disease. And there are special tests which we use specifically in younger patients who are more commonly affected by this disorder to diagnose it. For Fanconi anemia, we have this clustergenic assay. For telomere biology disease, we have telomere length measurements. And we do have genetic testing, special mutation panel, which we use to diagnose genetic abnormalities, which may be seen in these patients with constitutional marrow failure. So this is an example of one of the constitutional marrow failures, Fanconi anemia. And some of the patients will have additional abnormalities, skeletal abnormalities, as you can see on this photographs. But there are some other abnormalities which are not as obvious. So there may be changes in the shape of the kidney, duplication of kidney collection system, as well as some other abnormalities. So this is not something I see commonly. I'm an adult hematologist. This is what pediatric hematology colleagues are dealing with a lot of times. So this is dyskeratosis congenita. It's one of the telomere biology disease examples. And here are some other manifestations. In addition to bone marrow failure, these patients may have nail dystrophy, tan leukoplakia, and hypopigmentation of the skin. So telomere biology disorder is the entity which is recognized relatively recently and includes a number of conditions. Telomeres are ends of chromosomes, which protect chromosomes from damage. And with each cell division, they become shorter. So some believe that this is how our body ages, because telomeres get shorter, chromosomes become more vulnerable to damage. Certain abnormalities may accumulate, including genetic abnormalities. The ends of the chromosome, the telomeres, are protected by a special machinery, including multiple proteins you can see in the right upper corner here. And a lot of genes are involved to sustain this machinery. And so there are mutations which patients inherit, which may affect this machinery and cause shortening of the telomeres, premature shortening of the telomeres, leading to bone marrow failure and some other manifestations. So again, telomere length can be measured, and there are many genetic abnormalities which can lead to this. So initially we do the test, which allows us to understand that they're shortened, and then we can do genetic testing to clarify in most of the patients what type of genetic disorder is behind it. So, but most common aplastic anemia subtype is acquired aplastic anemia. So even though I say most common, about 90% of patients with aplastic anemia will have this subtype, it is a rare condition. So it's about 2 cases per 1 million per year diagnosed in the United States and Europe. It is, the prevalence is somewhat higher, the incidence and prevalence is somewhat higher in Asia, 3 times higher. The male to female ratio is 1 to 1, so equal gender involvement with this disease. And the affected age groups, you can separate 2 peaks. The first one at the age of 20 and the second one at the age of 60. So the patients with acquired aplastic anemia develop this condition for a number of reasons, but most commonly it is so-called idiopathic acquired aplastic anemia. So this is when we cannot say with certainty why this condition developed. More than half of the patients with acquired aplastic anemia will have this subtype, idiopathic. So there are other types, and we commonly see for patients who are treated for different malignancies with chemotherapy and radiation that they develop aplasia, which is usually transient and related to toxic effects of chemotherapy and radiation to the marrow. Some other medications which are used for different diseases, including antibiotics, anti-seizure medications, anti-thyroid medications, can cause suppression of the marrow. And a lot of times removal of this medication can help to restore marrow function. But sometimes these medications can trigger immune response from patient's immune system, which doesn't stop even after medication is discontinued, and damage to the marrow continues due to that triggered immune system. Toxic chemicals like solvents can cause damage to the marrow, as well as different types of infections, specifically viral infections listed on the right side. Immune disorders are associated with aplasia in the bone marrow, including eosinophilic fasciitis, lupus, graft versus host disease for those patients who receive transplants for other hematological conditions. And miscellaneous conditions have association, including thymoma, which is the tumor in the mediastinum, pregnancy, and anorexia nervosa. But once again, idiopathic is the most common. Now, when we're saying idiopathic, we don't know what triggered it, but most likely it is something which affected patient's own immune system to attack hematopoietic stem cells in the bone marrow. And hematopoietic stem cell is the mother cell in the bone marrow, which gives birth to all of the blood cells and eventually cells which circulate in peripheral blood. The hematopoietic stem cell has ability to replicate itself. And when whatever offending agent triggers the immune system, it can do it by directly, by affecting the immune system, but also through direct suppressive effect on the bone marrow hematopoietic stem cells, as you can see here. So the drug can directly suppress function of hematopoietic stem cell or trigger the immune system to attack that cell, leading to the same result, basically aplasia in the marrow and decreased blood counts and pancytopenia. So this is the schema of hematopoiesis. So the cells which are usually damaged by the immune system are in this red square on top, and they're called hematopoietic stem cells, progenitor cells. So this picture shows you in more detail how immune system can damage hematopoietic stem cells. And the brown cell there is antigen presenting cell. This is the cell which interacts with some antigen. It can be infection, for example, or the drug. And it presents this antigen to the immune system, to the cytotoxic T cells. After contact, these T cells multiply and start attacking hematopoietic stem cell. The other cells, the regulatory T cells, for some reason misfunction and do not control this activation of cytotoxic T cells. And as the result, we have damage to hematopoietic stem cells and development of idiopathic aplastic anemia or autoimmune aplastic anemia. So I would like to present a patient. The pictures here are not from the patient. This is from the article New England Journal of Medicine on thrombocytopenia, low platelet count. So this patient presents with similar findings. She has petechia as well as bruises on her extremities. She does have so-called wet purpura. You can see the bruises in the mouth, on the lip. And if it happens in the mouth, it happens throughout the GI tract, and that can certainly lead to significant bleeding. Usually when you see this type of manifestations, platelet count is very low, and that means in single digits. So this patient comes to the attention, and of course, as the result, she has a workup. And the first test, which is back, is complete blood count. We're looking here at pancytopenia. White cell count is quite low in our patient, including white cells, which are specifically responsible for fighting infection, called absolute neutrophil count. Normally, absolute neutrophil count should be more than 1,000. Our patient has 10 times less, 0.1, so or 100. So hemoglobin is low, very low, in fact. Patient is quite fatigued with this. Hemoglobin is 4.1. As you can see, normal is more than 12. Platelet count is low as well, and that's why we see this manifestations on the skin and in the mouth with hemorrhages. Platelet count is 8. Normal platelet count is more than 140. Absolute reticulocyte count is a mature red blood cell, so we can look at this indicator of bone marrow function. And if patient is anemic, marrow has to make a lot of young red blood cells, and reticulocytes are young red cells we can measure. If patient is anemic and those cells, reticulocytes, are low, that means marrow is not able to cope with anemia. Anemia can be from many different reasons. One of them is, for example, blood loss. And with blood loss, marrow certainly can ramp up the response trying to make red blood cells to compensate for lost ones. If marrow is not working, this is not happening. And so reticulocyte count helps us to understand the etiology of anemia. So, and when it is low in the setting of low hemoglobin and red blood cell count, that means we have a production problem. And this is part of the aplastic anemia picture. So this patient has pancytopenia. All of the counts are low. So the further testing, in addition to CBC, complete blood cell count, includes a number of tests listed here. And you just heard from Dr. Shu in the previous talk that we do flow cytometry for PNH, and I'm having a whole talk about that in the next hour. And then we do also test for T cell LGL. This is a co-occurring condition with aplastic anemia because when immune system suppresses abnormal clones appear, and they're somewhat protected against this immune system, and that's why they get an advantage and they can expand and cause clinical problems. So we'll do check for vitamin deficiencies and iron deficiency, as well as infections, which may play part in the development of aplastic anemia, as well as do rheumatology workup. Conditions like lupus can be detected in patients with pancytopenia, and that's why we're doing this test called ANA and anti-dsDNA. So younger patients, we have to be considering the congenital variant of aplastic anemia, which I spoke about. And there are certain tests we do for younger patients, including testing for Fanconi anemia, as well as testing for telomere length, as well as next-gen sequencing panel for genetic abnormalities associated with constitutional aplastic anemia. So only one word about PNH, because I'll be talking a lot more about it. So the abnormal clone which develops has an advantage. So it's a PIGA mutation. Glycoprotein GPI anchors are the cell surface anchors which help to keep certain proteins on the surface of the cell which protect those cells. Specifically, if you think about red blood cells, these proteins, CD59 and CD55, you can see here, this is the cell membrane, these are the anchors, and this is anchor attached protein 59 and 55. So these two actually help to protect red blood cell from being damaged or hemolyzed by complement system, which is constantly active and protects us against infection. So if they're missing because there is no anchor, there is no protection to red blood cell, and condition called hemolysis, damage of red blood cell inside the blood vessel occurs. And that can lead to a number of problems, including anemia, including thrombosis, because whatever is leaked out from that cell increases the risk of clots, as well as other clinical manifestations. And this condition is associated with reduced survival. In aplastic anemia, we see this in about 2/3 of patients, but most of these patients have very small clones. So they are helpful to say that there is immune dysregulation going on. It is much, much more common to see the small PNH clone among patients with acquired aplastic anemia than with constitutional ones. So it helps you in the differential diagnosis between the two in younger patients. It does cause clinically significant hemolysis and thrombosis in minority of patients. Among those who have it, who have the clone, only about 15% will need specific treatment for this PNH. And we'll talk a little bit more about this later. So what happened to our 51-year-old teacher's assistant? So fatigue and low counts, bruising, petechia, which is the dots on the skin, as well as wet purpura, the hematomas in her mouth mucosa. She received transfusion support with red blood cells for anemia, platelets for thrombocytopenia, and prophylactic antibiotics to prevent infection because her neutrophil count is so low. So workup in general was negative. Whatever I've mentioned previously was done, including flow cytometry for PNH, which was unrevealing. So when this happens, we actually, the answer for pancytopenia, because all of those cells are made in the marrow, we have to proceed with bone marrow evaluation. So this is the procedure we commonly do for many hematological disorders because most of them originate in the marrow, similarly to aplastic anemia. So this is the picture which we see on the left. Normal patient is 51 years old. You expect cellularity of about 50%. The big circles are fat cells, so half of the marrow should be like that. Another half should have cellularity, and this is what we see, in that marrow biopsy. On the right side, you see pretty much fat and very few cells, and that's what you see in aplastic anemia, so-called marrow aplasia. So in her case, that's what we saw, no cells other than fat cells in the marrow. So the cellularity was assessed as less than 5%. Her karyotype was normal, and diagnosis of very severe aplastic anemia was established. We quickly realized that that she's not responding to platelet transfusions because immune system actually takes out donor platelets, and that is causing refractoriness. And the problem is that if you don't have platelet response, you may be at higher risk of bleeding. So we would like to proceed with treatment as soon as possible because, this is a risky situation. The other issue which she's facing is infection because her white cell count is very low. And even with antibiotic prophylaxis, infection risk is significant. So why did I call her very severe? So this is the classification of aplastic anemia, and severity is based on white cell count. So if absolute neutrophil count, so by definition, you have to have low cellularity in the bone marrow, in general described as less than 30%, and then two of the following findings. Absolute neutrophil count less than 500, platelet count less than 20, absolute reticulocyte count less than 60. She actually has all three, and her bone marrow cellularity is less than 5%. So she does fulfill diagnostic criteria for severe aplastic anemia. So, but in fact, because her ANC is about 100, she fulfills the diagnostic criteria for very severe disease. And the reason why it is very severe because risk of infection increases with decreasing absolute neutrophil count and is much higher when it drops to less than 200. There are other group of patients with non-severe or moderate aplastic anemia. They do not fulfill the criteria above. They don't have severe cytopenias. A lot of times they don't require treatment, but they may have anemia requiring transfusions once in a while or borderline low platelet count, which makes it difficult for them to have, for example, surgical procedures. So the treatment for this condition sometimes is observation. This is for non-severe or moderate aplastic anemia, but sometimes mild immunosuppression with the drug cyclosporin. Sometimes we use L-Trombopac or Promacta for those patients to stimulate production of cells. Severe and very severe aplastic anemia require immediate treatment, so we try to treat them in addition to supportive care, which is transfusions and antibiotics. We try to start the treatment to downregulate the immune system and help them to make more cells, because if this is untreated, the mortality, the death from this condition can be quite significant. And 70% mortality is described in 1 year if patient doesn't receive aplastic anemia-directed therapy in severe and very severe cases. Most of the patients die from infection and bleeding, as I've mentioned. So there is a significant improvement in outcomes for these patients with severe and very severe disease. Since we started to use ATG in the 70s, and then combination of ATG, which is anti-thymocyte globulin, and cyclosporin in the 80s. You can see that responses to steroids alone, which are not considered good treatment for aplastic anemia, was 10%. And some of them were spontaneous improvements, most likely. So, but with ATG, the response rate is 40-50%, and with ATG and cyclosporin, both drugs are attacking T cells, modulating that immune response and damage which is done to bone marrow, 60-70%. So this led to improvement in survival among patients with severe, very severe aplastic anemia from 10% in the 60s to 90% from the beginning of the century. So this is 1 year survival. So a little bit about horse ATG, which is the kind of, it's ATG in general. It's not just horse. It can be either from horse or rabbit. So what happens here, the cadaveric thymus, the human thymus, is used to immunize these animals against T cells, which undergo modification in the thymus. And so thymus is very rich in T cells. And, so then the immune system of the animal generates the antibodies, which are collected, purified, and used as a drug. So obviously, this is serum from an animal, and a lot of reactions can occur. That's why this medication is not used as frequently as possibly necessary for aplastic anemia, and only used in big centers where they're familiar with it. It is also used in transplant settings to overcome graft rejection, and is used in solid organ transplantation as well as in allogeneic stem cell transplantation sometimes. So it is interesting that Paul Ehrlich and Russian scientist Ilya Mechnikov got Nobel Prize in 1908 for immunology. So it's basically physiology or medicine Nobel Prize, and they both got it for working on immune therapies. And Mechnikov was the one who was working on anti-lymphocyte serum. And, so both of them, and Ehrlich was the one who described aplastic anemia. So they actually thought to be fathers of immunotherapy, which is widely used these days in many conditions. So the administration of horse ATG or rabbit ATG is associated with significant, potentially significant side effects. And that's why the center which is using these medications has to be well equipped, and staff using this drug has to have understanding of the potential side effects and premedicate patients in the right way. ATG is given intravenously for 4 days. Patient has to be admitted and observed. And of course, the biggest issue is allergic reactions. After all, we're giving proteins from a horse or rabbit, and anaphylactic reactions can occur. So we have to be ready to deal with it. Serum sickness is prophylaxed against by steroids, which these patients receive for the first 4 weeks of their treatment. And these are some of my patients who had skin reactions. You can also develop arthritis as well as fever. So you can live with it, but it certainly can be significant and affect your quality of life. But most of the patients actually do reasonably well with steroid prophylaxis. Just want to highlight it that prednisone used in the circumstances is not used to treat aplastic anemia. It is used to treat or prevent complications of ATG, anti-thymocyte globulin treatment. So cyclosporin is also not easy to give. There are many different side effects, including on electrolyte abnormalities, hypomagnesemia, cramps, gingival hypertrophy, as you can see on the slide. And, there are certain tricks you can use to overcome these complications. And again, familiarity and skill with management of cyclosporin is necessary. And also, your lab has to be able to give you a good turnaround time for cyclosporin levels, which are adjusted to therapeutic range and can be adjusted down if necessary if patient is experiencing side effects. Not every place has it. And, of course, it makes no sense to have the level which comes back in 3 weeks because, you have to adjust this medication in real time. And cyclosporin is a pill you take twice a day. So the supportive care role cannot be underestimated. And I think in part, the success of aplastic anemia treatment in big part is related to supportive care. Of course, so if you have anemia and your hemoglobin is low as 4, you're very symptomatic and you may die from this anemia. So you have to receive blood products. You have to receive red blood cells to prevent symptoms related to anemia, and platelets to prevent bleeding. So we learned how to modify these products to make them safer. Patient with neutropenia is receiving antibiotics to prevent infection. Of course, it is not 100% proof. We do not transfuse white cells. It is not, an easy task, and it is not really clear if transfusion of white cells actually works to prevent infection. But we do give them antibiotics, antivirals, and antifungals. When patient receives immunosuppressive therapy, you become somewhat immunodeficient from it. And there are certain infection risk related to this. And that's why patients receive prophylaxis with acyclovir against shingles, the painful rash, as well as inhaled pentamidine for special type of pneumonia called PJP. And this is inhaled treatment, which you receive once a month. Usually, cyclosporin is given for at least 6 months at therapeutic levels, and that's the time while you're having pentamidine. And acyclovir is only given when you combine cyclosporin with prednisone, which is the first months of treatment. So eye inhalation can be part of the treatment for those who receive chronic transfusions of red blood cells. So this is the algorithm of initial management of severe and very severe aplastic anemia. First of all, if you can identify the drug which caused the damage or triggered the immune system, it is imperative to stop that medication. And if there is infection, you can treat it, and that may help to improve marrow function. So, but a lot of times, whatever triggers immune system is gone, but immune system is still damaging to your marrow, and you have to take measures to cool off the immune system response to it. So how do you do that? So the approach is based on patient's age and availability of HLA matched sibling donor. So in general, patients who are less than 40, younger patients who have sibling donor, which is who are HLA matched to them, we can proceed to allogeneic stem cell transplant. My task is not to talk about this. You will hear the talk about this later. So, but most of the patients actually, so because they are older or because they don't have a donor, they receive alternative treatment, which is immunosuppressive therapy. We already spoke about HOS-ATG, Rabbit-ATG, and L-Trombopag and cyclosporin. In addition, we're using L-Trombopag, which is relatively new addition to immunosuppressive therapy, which improved outcomes for these patients quite dramatically, and I'll be talking about it in the next few slides. So this treatment is actually going on for about 6 months, and then L-Trombopag is usually discontinued, and cyclosporin is tapered and continues for another 18 months and stopped if everything goes well. So this shows you the outcomes of transplant in different age groups, and that's why it is preferred for younger patients, because they do better than patients who are older than 40. As you can see, this is long-term survival of 86% for patients who are younger than 20 when they are treated with transplant, and only 55% for patients who are older than 40. So bone marrow is actually used as source of stem cells. Most of the transplants we use, allogeneic stem cell transplants, we use to treat hematological disorders, hematological malignancies. Stem cells are collected from peripheral blood of the donor. In patients with aplastic anemia, collection from the donor happens from the bone marrow. So basically, these donors are having this multiple bone marrow biopsies under anesthesia when stem cells are collected. And the reason for this is when you collect them directly, stem cells directly from the marrow, rather than catching them when they circulate in the blood, is that there is a lot less incidence of graft versus host disease, which is not necessary in patients who don't have malignancy, like aplastic anemia. We just want them to get a new immune system. And that's why marrow stem cells are preferred, because we have less complications down the road. So the reason why HOS is circled is because HOS-ATG is preferred type of anti-thymocyte globulin for use in an upfront setting when patient is getting immunosuppressive therapy. Rabbit is better tolerated, but this study, randomized study, showed that survival is improved when HOS-ATG is used, and that's why we are using this particular drug when we're treating newly diagnosed patients with severe aplastic anemia. There were a lot of other efforts to improve the outcomes of immunosuppressive therapy, but so nothing other than HOS-ATG until we discovered the role of L-Trombopag. So our patient who had very severe aplastic anemia started treatment on this phase 1/2 clinical trial at NIH, which looked at addition of L-Trombopag to classical immunosuppressive therapy with HOS-ATG and cyclosporin. So why L-Trombopag? So L-Trombopag or Promacta is the medication which we're using for patients with immune thrombocytopenia since 2008. Thrombopoietin is the molecule produced by the liver which stimulates production of platelets by stimulating megakaryocytes, platelet precursors in the marrow to make more. It turns out that thrombopoietin is also stimulating hematopoietic stem cells, and for that reason, The L-Trombopag, initially used for treatment for immune thrombocytopenia, or condition associated with low platelet counts, was tried in patients with aplastic anemia because you anticipate the effect on stem cell and multilineage response, not only improvement of platelets, but also perhaps improvement of anemia and improvement of leukopenia. So initially, the first study only included 43 patients, and this was the patients who either didn't respond to immunosuppressive therapy or who relapsed after immunosuppressive therapy. And 40% of those patients responded after 12 weeks of treatment. And half of those patients, or about half, had multilineage responses, not just platelets improvement, but improvement of anemia and improvement of leukopenia. And interestingly enough, out of this, half of the patients had this response continued after L-Trombopag discontinuation. So that led to the approval, small study, small phase 2 trial led to the approval of L-Trombopag in the second-line treatment of patients with severe aplastic anemia who had insufficient response to immunosuppressive therapy. This approval occurred almost 10 years ago in 2014. So the study was expanded, and additional 40 patients were added, and the treatment continued now for 6 months, for 24 weeks. And it turns out that keeping it going for 6 months had improvement overall response rate from 40 to 50%, but multilineage responses increased significantly, as you can see. So the red part of this bar graph, shows the responses which affected more than one line. So one thing which was detected after 6 months of treatment with this drug, with L-Trombopag or Promacta, is appearance of genetic abnormalities. About 20% of patients had them, and some of them had the chromosome 7 abnormalities, about half of those patients with chromosomal abnormalities. And chromosome 7 is important because if you develop abnormality in that chromosome and you have cytopenias, that is diagnostic of myelodysplastic syndrome. And this condition is connected to aplastic anemia, even though we have separate talks. One is going on in this room and MDS talk in another room. There is certainly a connection between the two. So an MDS with monosomy 7 is significant because it has poor outcomes, and you have to consider transplant, allogeneic stem cell transplant for these patients. So, of course, initially it caused concern that, additional Trombopag can translate in a higher incidence of MDS and aplastic anemia. But I'll show you the data which says differently, that it is safe to add L-Trombopag. But first, the study which led to approval of L-Trombopag addition to immunosuppressive therapy. That study was conducted at the National Institute of Health, and our patient was referred to NIH for participation in this particular phase 1 trial. It's called ACE, ATG cyclosporin L-Trombopag. So, and there were 3 cohorts. Everyone received immunosuppressive therapy with HOS ATG and cyclosporin. HOS ATG was given for 4 days in the hospital intravenously. Cyclosporin is a pill twice a day for 6 months. Cohort number 1 received L-Trombopag, a pill once a day from day 14 to 6 months. Cohort number 2, day 14 to 3 months. And cohort number 3 from day 1 to 6 months. And this cohort, the green bar, is the winner. So most of these patients responded more than in other 2 cohorts, and that's what we're going to follow. And these patients were followed over a 5-year period to understand what happens to them long term. So the study led to approval by FDA of this combination in 2018 for frontline treatment of patients with severe and very severe aplastic anemia. The table shows you the comparison of responses between patients who were treated, and this is historical controls, with immunosuppressive therapy alone. HOS ATG, which is anti-thymocyte globulin and cyclosporin, both suppressing the immune system, and the new treatment, which is immunosuppressive therapy just mentioned, and L-Trombopag. So in addition to suppression of the immune system, L-Trombopag actually is not suppressing immune system, it stimulates production of cells. So the 3 drugs attack the disease from different angles. And as you can see, response rate increased from 60 to 79%, and complete response increased by a significant number, almost 30%, from 17% to 44%. And of course, the follow-up at the time when the study was published was not long enough to understand if there is an effect of L-Trombopag on clonal evolution. And that's why it is important to see what happened to these patients down the road. But first, I just want to say that response was more common and faster with combination treatment than with immunosuppressive therapy alone. So the other study, which was published later in our leading New England Journal of Medicine, this is the leading publication for physicians in the United States and the world, and only high-quality studies are published there. This was now RACE trial, so it's ACE, which is ATG, cyclosporin, eltrombopag. R is for randomized. So this was a randomized, non-blinded study in Europe. So the difference here is that eltrombopag actually started on day 14, and HOS ATG obviously together with cyclosporin on day 1. Why delay is because there is concern of liver function test abnormalities, which may happen with HOS ATG, with cyclosporin, and with eltrombopag. So there was concern which led to this delay of eltrombopag initiation. So even though NIH study by then was already published, this study was designed before this publication. So it pretty much confirmed the findings of an NIH study, which was published previously, and showed that at 3 months, the response rate, hematological complete response rate, when you have platelet count more than 100, absolute neutrophil count more than 1,000, and hemoglobin more than 10, was doubled in the group which received 3 drugs rather than 2 drugs, just immunosuppressive therapy. Similarly, overall response at 6 months was significantly improved by a combination treatment with eltrombopag when compared with immunosuppressive therapy alone. So our patient was treated at NIH 2 months. Her CBC, complete blood count, became normal. Just not even complete response, just it became normal. And she at 6 months had normal labs, and her marrow was repeated and had normal cellularity. Eltrombopag was discontinued as per protocol, and cyclosporin dose was reduced by 75%. At that point, monitoring of cyclosporin is not necessary. Patient was taking 100 milligrams daily for about 18 months. So 18 months after, she developed mild pancytopenia, and marrow evaluation was performed. She was found to have dysplastic changes in the marrow, as well as monosomy 7 and 5 out of 20 metaphases. So this is this concern: can eltrombopag increase chances of evolution into MDS? So this is what happens to patients who receive a combination treatment, immunosuppressive therapy and eltrombopag. About 2/3 or of the patients, about 70%, 75% respond to treatment. About half of those patients have complete response. And then, so among those who responded, which is overwhelming majority, about a third will have relapse. Either partial relapse when counts decrease just a little bit, or complete loss of response, where they become the same as they were before treatment was initiated. 15% of patients may evolve into AML and MDS. This is over the period of 5 to 10 years. And then 2/3 of patients will have a small PNH clone, and only 15% of those will have significant PNH requiring separate treatment. So what happens to patients? We continue to follow them after they respond to make sure we can address those issues when they appear. And bone marrow is performed when blood counts decrease. We are following PNH clone by flow cytometry, testing them at the time of diagnosis, and then 3 to 6 months during the first 2 years, and then yearly thereafter. So this is the long-term study follow-up for those NIH patients who had great response with a combination treatment. And it turns out that there is no increase in incidence of MDS. So first of all, risk of evolution. It's evolution to MDS and MPN, and this is again in blue, historic controls, and EPAG-EST is that group of patients treated on NIH trial, which showed advantage of addition of eltrombopag. So you can see that there is certainly evolution, as I said, 5 to 10% of patients over years. And, so this is the same in both groups, and median follow-up of EPAG-IST group is only 4 years. Historical controls somewhat longer, 7 years. So relapse, this is when counts normalize and then decrease, again, was similar in both groups as well. So even though patients with triple therapy respond better, the relapse happens very similarly in both groups, treated with eltrombopag or not, which is important findings. The conclusion of this publication was that evolution to myeloid malignancy, MLO-MDS, was not increased with addition of eltrombopag to immunosuppressive therapy, and relapse and clonal evolution was the same. So perhaps clonal evolution occurred a little earlier with eltrombopag, so because it does stimulate different stem cells, including the ones which have cytogenetic abnormalities in them. So So this was very reassuring, and I think it allows me to counsel my patients that additional Thrombopag doesn't mean higher incidence of transformation to AMDS and AML in our patients. So our patient, as the result of this evolution, proceeded to allogeneic stem cell transplant, and 3 years later, she's doing well. So I did show you the schema of frontline treatment. This is expanding to what happens to patients who didn't respond to initial treatment with immunosuppressive therapy and L-Thrombopag. So again, is minority of patients, only 15% among those who are treated. You can see that so we look at this at 6 months, and if there is no response and patient is eligible to transplant, we go with different types of transplants. Again, this will be discussed later. So if there is response, we stop L-Thrombopag and taper cyclosporin. That's what happened with our patient. And then we continue follow-up, looking for relapse. And there are certain things we can do when this happens, including retreatment with immunosuppressive therapy, not with horse, but now rabbit ATG, because now patient is immunized to horse, and that can cause significant allergic reactions. So rabbit can be used. About 30% of patients will respond to that treatment. Or if there's clonal evolution, like in our patient, chromosome 7 abnormality, we're considering allogeneic stem cell transplant. There are other genetic abnormalities which may occur, including mutations and genetic abnormalities which are low risk. And in those circumstances, we just continue to follow these patients. So in conclusion, aplastic anemia may be constitutional, but in minority of patients, 10%. Most of the patients with this disorder have acquired disease related to immune system and autoimmune response to patients' own stem cells. Hematopoietic stem cells, telomeropathy, biology disease, and telomere biology disease and Fanconi anemia testing is necessary to exclude constitutional disease, constitutional aplastic anemia in younger patients. The classification of aplastic anemia to very severe, severe or moderate is based on neutrophil count because of risk of infection, which is the major cause of death for these patients. Newly diagnosed patients with acquired severe aplastic anemia should be treated with transplant if they have a matched donor and they're younger. If there is no donor and they're older, immunosuppressive therapy with L-Thrombopag is current standard of treatment since 2018 when this combination was approved by FDA. L-Thrombopag is effective as a single agent for refractory severe aplastic anemia patients, but of course this is true when L-Thrombopag was not used in the frontline setting. Finally, relapse, development of clinically significant paroxysmal nocturnal hemoglobinuria and clonal evolution may occur after initial treatment with immunosuppressive therapy and L-Thrombopag, but allogeneic stem cell transplantation may be curative for some of these patients. Thank you for your attention.
Thank you so much, Dr. Podolstev. Do we have any questions in the room? No, I do have a couple of questions from online. The first question says, I'm a patient who was diagnosed many years ago with aplastic anemia and was successfully treated with ATG. I now have been diagnosed with LGL. Is this common for aplastic anemia to evolve into LGL? What are the treatment options to consider? When do I start my treatment?
Yeah, so PNH and T-cell LGL leukemia, large granular lymphocytic leukemia are common associations with aplastic anemia, and similar to PNH clones, TLGL clones may evolve because they have certain protection against immune attack on the marrow. And, so when they expand, they may become significant. Sometimes they're just, there on the flow cytometry test result in very small quantity and then may not require treatment. So, but usually when counts become low, and with T-cell LGL leukemia, it's usually neutropenia, but other counts can decrease as well. So it becomes important to understand if this is relapse of aplastic anemia or it is TLGL-related suppression of hematopoietic stem cells in the bone marrow. Usually the treatment is necessary if neutropenia is severe. There is a higher incidence of infection if other counts are low to the degree when transfusions are considered. So it's a little debatable, who should be observed and who should be treated, but certainly if absolute neutrophil count is less than 500, especially if there are infections, some people will say NC less than 1,000, treatment has to be considered. So what you're trying to do again, so you're trying to suppress this clone. So interestingly enough, the same cyclosporin can sometimes help because those are also T cells and can be suppressed by this drug the same way as immune system of the patient when we're struggling with aplastic anemia. The other treatment which is commonly used for these patients is weekly methotrexate. Again, so weekly methotrexate administered as a pill, maybe somewhat better tolerated for some of these patients. And there are certain molecular abnormalities in those TLGL cells which may help us understand who may respond better to methotrexate or to cyclosporin. So, the weekly methotrexate would be another treatment, which can help to control that T cell LGL clone and improve blood counts.
Thank you. The last question from online says, how long after completing IST should a patient wait to see if they're responding? What is considered a good response?
Yeah, so you saw that I was talking about complete response. Complete response is absolute neutrophil count more than 1,000, platelet count more than 100, and hemoglobin more than 10. So this is a hard endpoint which is used in the study to look at effectiveness of treatment. But in real life, clinically significant response may not be as robust. But if patient required constant transfusions, if patient was suffering from infections, and now absolute neutrophil count is in range where infections are not happening and transfusions are not necessary because hemoglobin improved, because platelet improved, to me, it is also clinically significant, even though it is partial response. So immunosuppressive therapy takes time to work. Most of the patients do respond with triple therapy within the first 3 months. So, but we usually wait up to 6 months to see the response. And then at 6 months mark, we judge if there was response or not, and then decide if it is primary refractory disease or there is partial response or there is complete response. And usually marrow also helps to understand what's going on at that time. So it is repeated at 6 months mark.
Thank you so much, Dr. Podolstev, for sharing your time and expertise with us today.